Hey moms, when we know better, we do better, right? Well, that's our mission. This is MomCast, powered by the Local Moms Network. I'm Endometriosis, coming to you from Stanford Studios, and I'm so happy we're in this together. Moms, there's so much sacrifice that goes into what we do. It's just part of the job sometimes. But suffering in silence is never okay, especially when it comes to our health. Think things like painful periods, chronic fatigue, pelvic pressure. All of those need our attention, and today we're going to get it. Joining us are Dr. Carly Provost Goldstein and Dr. Lee Rosen. Thanks so much for being here. They're both board-certified, minimally invasive gynecologic surgeons at Esse. It's a boutique practice on both coasts in LA and here in Manhattan and Fairfield County, Connecticut. Welcome.
Thank you so much for having us.
What are some of the red flags that you hear about most in your practice that we really need to pay attention to?
I think we hear a lot, of really painful, heavy periods, irregular bleeding, right? And I think a lot of women and patients are just dismissed a lot and they're told, oh, just go on another pill or, just try another birth control. It's normal. Everything's normal. They're sort of told that any kind of gynecologic problem could be in their head or it could be normal, whether it's really heavy bleeding postpartum, whether it's, really painful periods, whether it's a total change in what's happening with their pelvis. And they're like, it's part of having a baby and being postpartum,
right.
And they're sort of just dismissed a lot.
That's such an interesting phenomenon. Women are told that we need to trust our gut as a mom. Yet doctors dismiss some of our concerns, and it's so frustrating because we know something is going on. We just need the attention.
Correct. Yeah.
I think also something that I see specifically with moms is that as a mom, you're often not focused on yourself. You're literally taking care of everybody else around you. And I meet a lot of people who, when I really kind of talk to them, they're like, oh, yeah, I've been bleeding a lot. I'm like, what's a lot? Explain it to me. And it's like really severe. And they've been suffering like this for not like 1 month or 2 months, but like some people years. And I think that that's a common thing I see where, moms aren't really putting themselves first.
So let's start with step one. How do we diagnose what's going on? When someone comes to your practice and talks to you about these concerns, how do we even find out what's going on?
Yeah, good question. And some of it, may take a little bit more than just that first visit, right? So we may do a visit. Sometimes I do longer visits in the office. I'll do a transvaginal ultrasound or a pelvic ultrasound as part of the visit. Sometimes we get an MRI if we're worried about the entire sort of abdominal cavity, the pelvic cavity, and we want to assess what the uterus looks like and what different organs in relation to the uterus looks like. So it may not all happen on that first visit, but it will help point us in the direction of where we need to go. And sometimes we're able to sort of even pre-screen before someone comes and say, that patient really needs an MRI. Can you guys grab it for him before they come so we can make use of their visit a bit more? But yeah, certainly we do imaging, which helps us. We do an exam of the patients, a pelvic exam, and really just listening to the whole story and what's happening is a big clue, like you were saying before, of like trusting yourself. Oftentimes the patient's story and their symptoms and specifically when they're happening is really important to kind of get to the root of the problem.
Plus, a lot of people don't know what's normal and what's not because
great point.
Like we know because what we do is this is all we do all day is talk to people and try to figure out what's normal in terms of a period or bleeding or pain and all of that. But if you're a person and you're not having this discussion with multiple other people, you might just think that what you're going through is normal. I've always had really painful periods, or this is just me, or like I've always been having really heavy long periods. So people don't always know that what they're experiencing isn't actually normal. So much of that is just pointing out like, hey, that's not normal.
Yeah, and I think postpartum is such a difficult time and we're getting to know our body in a different way, a body that will never be the same as it was before, if we're honest.
Correct. Yeah.
Because internally so much is going on. And I know one of the concerns might be, well, I don't have downtime. I'm taking care of kids.
Yeah.
I'm trying to work. I'm trying to run a household. I'm doing so many things. Okay, and if they find something, I just don't have time to fix it.
Right.
Help us with that misconception because minimally invasive surgery is what you do, it doesn't necessarily mean you're going to be out for a long time just because you have to take care of yourself.
Well, I often, when I'm having a conversation with someone who's in that situation, like, I've got this, my kids have this, and I understand and I get it. But when you are experiencing debilitating pain and bleeding, you are not your healthiest self. You don't have the energy. You're not, it's kind of like taking a pause to take care of the issue so that, you'll ultimately be healthier and be more involved, be more present, have more, stamina to actually do all of the things that you're doing all the time.
Yeah, and we know, obviously, when moms come to us and they have several kids or maybe even just one, but then they have all these things going on, we're like, I already know it's like a lot to get to the office at that morning and at that point. And I know that, moms are super strong and very stoic and they've been through a lot and they can handle a lot. And
it's almost a badge of honor that we can handle anything.
Yeah.
But really, we don't have to be suffering.
No, exactly. No, and I have patients sometimes that say, whatever pain they're dealing with is worse than their labor pains, and that's how they know it's something wrong.
Oh my God.
And it's like, and I could handle labor without an epidural, but this pain is worse than that. And I'm like, well, that's a huge red flag, right? And so it's like it's a totally different perspective when they're walking in the door, and they've, and so I think, to answer your point about having the downtime for it, for instance, like a C-section, you're recovering from a major laparotomy, a major open abdominal surgery, while holding a newborn, feeding the newborn, maybe breastfeeding as well, doing all of these different things while you're recovering, trying to get ready if you have to go back to work. It's a massive undertaking that, we just go through, and we're sort of just like, you handle it and you deal with it because you have to, right? And this little being is depending on you. And so you handle it. But doing these minimally invasive surgeries, it's sort of a cakewalk for most patients compared to like a C-section with a newborn and sleep training and all the other things that you have to do at that moment, And so a lot of patients that have been through that before, it's like, oh, that was very different. I had one mom recently that, we did a combined procedure for a minimally invasive hysterectomy and then a mommy makeover at the same time, a tummy tuck. And
ooh, I like that, a twofer.
A twofer. It's one of my favorites. It's so fun because it's like they're getting rid of like the heavy, painful adenomyosis and painful bleeding and terrible things that are plaguing them while also giving something back to themselves. And they gave up their body for their kids. And like, then we get to restore something and on the inside and out. And it's super fun. And then I feel like they get to feel better about it because they can say they had the hysterectomy, but really they got something good on the outside too. And so
do you do both parts, both the aesthetic portion?
No, the aesthetic portion is done by a board certified plastic surgeon who's fabulous.
But at the same time.
And the patient stayed overnight and we went to see her that afternoon, and she already like eating chicken, enjoying life, watching TV, and having a nice break from the house. And I called the
it
husband.
Takes surgery to get a break from the kids.
It takes surgery to get the break. She stayed overnight, enjoyed her stay in a private room. The husband called. I said, are you coming to the waiting room to see her? He said, no, I'll pick her up in the morning. She drove herself to the hospital. She'll be fine. She's a good one, And I'm like, okay, we're like, you just take all the time you need in this private room with your food and your screen and, watching whatever we're watching. And it's like,
we laugh about it, but think about the mental energy that it takes, like you said, to come into the office, to plan this and then to make it happen.
Yeah.
It's been a long time coming for a lot of patients.
It has, yeah.
What do they get from you that we're just not hearing at other doctors? It feels like there's a disconnect either in the education or just the experience in what they're seeing.
I mean, I think something that's like kind of the whole premise of the care that we give, which is ensuring that we have enough time to sit with the patient and really get to know them and understand what they've been through, what they're going through, and what they want to achieve. Because everybody's different. Everybody's coming to the visit with, different experiences, traumas, all sorts of things. And so getting, the amount of time that we feel is necessary to really get to know somebody and understand what they, what they're suffering from, what they need, and how to help them. I mean, I think that's, and certainly never, ever, making anyone feel like they should feel strange or embarrassed or anything about what they're going through.
I'm so happy you mentioned embarrassment because sometimes we just don't feel okay coming clean to a doctor about what we're actually experiencing.
Yeah.
That shame can be such a setback instead of a source of a solution.
Totally.
Right. Exactly. Yeah. And there's a lot of, but I think when we can have an open, candid conversation about all different things and what's working, what's not working, and what's happening with your digestion and your bladder and all these different things, there really is no judgment there. And it's like, it's all information that can help us to figure out what the problem is, so.
You mentioned bladder.
Mm-hmm.
Moms have a problem with that. If not right away, then in the near future. How do we solve something like that?
It's great. So we have great pelvic floor therapists we work with, and I have some really trusted ones I send to, and I'm always meeting more, but we collaborate a lot with pelvic floor therapists. And I think that's always a great place to start, is that pelvic floor therapy, it's a physical therapist that does an evaluation of the pelvic floor. They do a vaginal exam. They see sort of how you're holding your bladder, and they're able to do some exercises there in the office and some work, and then teach you how to do things at home. And I really encourage patients to do this, even just as a baseline evaluation and just for information, at least to go once. It's really important, rather than trying to YouTube or, look stuff up online and figure out how to do a Kegel or something like that. I see a lot of endometriosis patients. For my patients, it's actually super detrimental to do Kegels because their pelvis is usually in a state of tightness all the time anyway. So I really like having a trained physical therapist on board that helps them with what they actually need to be working on, right? And they'll tell them certain things like letting the urine stream go, then holding it, not to pee in the shower. Like, they have all these things that they work with them on. And, just that we really don't have time to sit there and work with them on the visits, and we don't have the training in it. But I do think it's really important to have someone that's trained in pelvic floor, at least for 1 or 2 visits, to teach you the right ways to sort of get the bladder back into shape. And, with childbirth, the vaginal mucosa really stretches, and there's a lot of, there can be tearing, there can be breakdown of the support system of the pelvis and the pelvic floor. And so getting that back, or teaching you tricks on the right way of doing that, is super important,
If surgery is necessary.
Yeah, so I was going to say one of the things you said when we started this was how people are suffering in silence, like just suffering, and so I think one of the key things about spending time with their patient and getting to know and getting to understand what they're going through is finding out, are you someone who is leaking urine when every time you cough, when you exercise, when you run around, or, and how much is that bothering you? Because if that is something you don't have to. And so usually, in addition to pelvic floor physical therapists, if surgery might be something, then I work very closely with urogynecology surgeons who are gynecologic surgeons who focus specifically on things like bladder issues, prolapse, things like that, which can also be very common in the.
And usually those surgeries, if they're recommended, they'd be recommended after all childbearing is done. So after you're done having all the kids, you wouldn't want to do a repair and then have another pregnancy, and then, it could break down the repair or put you at higher risk for, so it's better to consider those sort of repairs after you're done with all of the kids. And in the meantime, you can learn tricks like pelvic floor therapy. There's actually even little vaginal inserts that can help lift the bladder. It's kind of like a tampon, but it's a little bladder lift. And there's things like this over the counter that can be done.
I've never even heard of that before.
Yeah.
I imagine the technology for this changes so rapidly. So there are more options than we might even know.
For sure. And some of the bladder lifts they do now are, very minimal. I know the word mesh is always scary, but very minimal mesh, and that can be done vaginally. And, there's approaches like this that are really sort of very in and out for their procedures, or like 15 minutes. And, they're still done at a surgery center or something, or a hospital, but, it's not a lot of downtime for things like that. So,
Dr. Rosen, you mentioned helping moms get pregnant again, whether it's secondary infertility issues or for the first time.
Yeah.
Tell us about ways that you help women become mothers.
So I work very closely with other OBGYNs or fertility doctors, so reproductive endocrinologists and infertility specialists. So if a patient is struggling to get pregnant, they might be evaluated by one of these specialists. And in their evaluation, they find that there's a structural issue that could be preventing them from getting pregnant or making it more difficult. So things like fibroids, uterine septums, scar tissue in the uterus, polyps, problems with your fallopian, any of these, any kind of thing. And then they'll get sent to me to have a surgical procedure to address that issue. And after that, hopefully they'll be in a better place to be able to get pregnant.
I know no case is typical and everyone is unique, but what does downtime for something like that look like? Are we talking days, weeks?
Right. No. So typically the procedures are minimally invasive. What does that mean? So, for example, if someone has a polyp or scar tissue in the uterus, that's usually treated by a minor surgery called a hysteroscopy, which is basically a procedure that's done vaginally. So there's no incisions, there's no cutting, anything like that. So it's done in the morning, you go home shortly after. Many people feel they can resume all normal activity the next day.
Wow.
Some of the more invasive surgeries that are, still within the category of minimally invasive, small incisions are done. So it's kind of, it's instead of when we think of traditional surgery, we think of maybe a larger cut or something like that. This is done through smaller cuts, and usually it's done and then you go home the same day, maybe 2 weeks of kind of some downtime with a little bit of a longer in terms of limited exercise, limited physical things. But
for instance, Dr. Rosen did 3 hysteroscopies this morning, the vaginal cameras, then came over here to do the podcast.
Wow.
And those patients leave within an hour or 2 of their procedure and go home. And they're done often at a surgery center. And they go home in a few hours. So it's not as overwhelming as going to a big hospital. When she does these on a Thursday, she may do 10 in one day.
That's incredible. Do any of these cases have something in common? Is there something that you're seeing more and more of that women can say to themselves, I'm not odd for having this issue?
I think a lot of people are being more proactive in trying to evaluate their fertility, which is wonderful. And so people are getting a lot more information, often even before they've even tried to get pregnant, which I think is why sometimes I'm finding things, or patients are coming to me with a condition and they haven't even tried to get pregnant yet. They found out about it because they've wanted to assess their fertility, met with their doctor, and they want to be proactive. So I feel like maybe that's something that's been changing, which I think is a good thing.
That's so interesting to me. I think we have a lot of information in this age, and we don't want to depend on Dr. Google, but there is a general awareness, which I think is such a beautiful trend for women.
Yeah.
I think 13 years ago when I became a mother, I thought I knew a lot about how to get pregnant and had heard enough women's stories and had researched different things. But today, this conversation, literally this conversation here, is part of a changing trend, I think, that mothers have access to so much good information.
I agree.
How are you seeing that in your practice?
I find in my practice, I do a lot of endometriosis. And so most of my patients, I would say 90 to 95% of my patients find me on their own online. I don't have referrals. So I have a few referrals from a couple of fertility doctors, but most of my patients actually find me by doing their own Googling. They're looking on Reddit, Facebook, Instagram, things like channels like this, and they're very well interconnected and super educated. And, I think an endometriosis patient that's been suffering for 20, 30 years, like by the time they get to my doorstep, they almost have a medical degree in everything that they've been going through and all the procedures they've had, and 3 colonoscopies and this many doctors for this and this situation. And, it's awful, but it's the average delay for diagnosis for endometriosis is about 10 years for that they may see different doctors.
Why is it so tricky to diagnose something like endometriosis?
That's a good question. So endometriosis, stage 1 and 2 disease, is really not visible on imaging. There are some ultrasound techs, in the world right now saying that they can pick it up on transvaginal ultrasound. I did talk to a patient about this the other day that had endomapping, and she sat there for the transvaginal ultrasound for 1 hour while they were trying to pick up small lesions in the back of the vagina. And that's a long procedure to have a vaginal probe inserted for a long time. When we do things like MRI and ultrasounds, unfortunately, the resolution for things like endometriosis, it can pick up nodules that are about a 0.5 centimeter or bigger. And a lot of endometriosis, especially in its early stages, are like 1 or 2, 3 millimeters. They're so small that it's very difficult to pick up on imaging ahead of time. So I can pick up big ovarian cysts on imaging. We can pick up fibroids. We can pick up big uterine disease. But often, and we may pick up a polyp, an endometrial polyp with certain types of sonograms, but it's often hard to pick up smaller disease than that. And so a lot of endometriosis is just not heavily or readily visible on imaging. And so that's why patients sort of are dismissed and they're told, I hear it all the time, they're told they don't have endometriosis. They may be suffering with infertility for years, failing IVF even, or they may have secondary infertility. They may have had pain and severe bleeding and severe sharp pain in the pelvis, rectal pain that developed after their C-section. And then their doctor says, oh, there's nothing wrong, and just, carry on and go on the pill or whatever. And you can in fact develop endometriosis if you've never had it in your life. You can develop it after a C-section, or after vaginal delivery. So, there's a lot of misconception and misinformation circulating, even from the medical community, unfortunately. And I see patients all the time that are told by their fertility doctor or their OBGYN that they don't have endo, or they don't think they have something like that, and they're dismissed. Or they say, you may have endometriosis, but there's nothing to do about it except go on birth control or do hormone suppression with Lupron or something like that. And so they're really given no options. And then people will tell them, oh, the surgery is risky, the surgery is dangerous, or you shouldn't have it. They can remove your ovaries. They'll just tell them really scary stories so that the patient won't really
that are
seek
worst
help.
case scenarios.
That are worst case scenarios and not
common.
often. Yeah, I've never had to emergently remove an ovary. Never.
Would you say that you start surgery for endometriosis and find a lot more?
Yes, always.
Interesting.
Patient's always right. So their story is like a map of where it all is in their pelvis. And I have an expert PA who has 15 years of experience, who's my bedside assist and works with me. And she tapes the patient's story and history up on the robot. And I look at it, the whole case, and I'm like, okay, where else? Their right leg pain. They have this pain down their groin. They have this, they lean backwards to have a bowel movement. That could be an adhesion by the rectum. And
so during surgery.
Yeah, I look at the notes. Yeah.
Wow.
I could try to memorize them, which I did before when I was in training, but it's nice to have them there, and it's like a checklist. And I want to make sure that I've gotten through and looked at all their points.
That's incredible.
Yeah, it's super helpful. It's like she's a rock star helper, and that's like, it's so nice to have that.
It's just amazing to hear the partnership between a doctor and a patient.
Yeah.
You're literally exploring symptoms together and finding the solution in real time.
Absolutely. It's like, I tell them, it's like a big hide and seek. It's the big reveal, and I videotape my whole surgery for them. And then Sonam, my assistant out there, makes a 3-minute highlight reel for them so they know all the important part of their cases. So, with endometriosis taking so long and they've been dismissed for so many years, it's often such an emotional journey to finally get help, and they don't even believe it, or they're still emotional when they wake up and I tell them they have so much endo. They know it, and they knew it all along. They felt it.
They're crying tears of relief.
They are, and they're so angry about all of the other years. And what I say is, I always say, what we're going to do is we're going to print out the operative report, and we're going to print out your pathology report of all the endo. And then you can fold that up and put it in an envelope and mail it in a thank you card to everyone that's ever helped you or not helped you, and say, listen, please don't dismiss other patients. I had a real disease, and please look this over and think about your future patients. And I say that's the best way, in my opinion, to sort of to get through that anger and that kind of, resentment of everybody in the past, and maybe to help with education and teach people in the future, like, oh, wow, I did have trouble with that patient with IVF and she did have endo. Look at that, so.
The warning signs are there. Someone just needs to connect all the dots.
Correct. Yeah.
Tell me about the experience a patient has coming to see you, because obviously this feels very different. What is the gap that you're filling?
We ensure that we have time to sit down. I want to hear everything. I always have all the records in advance. They've sent me imaging, they've sent me prior doctor's notes, and I, of course, review all of that. But I say, put it over there, and then I say, all right, can you just tell me? I want to know everything. I want to hear your story. And most people are like, oh, well, there's a lot. And I'm like, let's go. That's why we're here. And I want to hear everything from the very beginning. And then, I think it's really just about getting to know the person, who you are, what you've been through, what you're suffering from, and what you're trying to achieve, and really just listening. And that's the first step, getting to understand who you are as a person in addition to what your symptoms are. And then trying to go through all the options, everything. Sometimes it's not surgery. Sometimes there are less invasive things that can be done that no one's ever even talked to you about. Mm-hmm. And I think, it's so important, getting to know the patient, presenting all the options out there, and then coming together to figure out what's the best, next step.
I do endometriosis multiple times a week. I do very difficult hysterectomies, very difficult frozen pelvises multiple days a week. Dr. Rosen is one of the most advanced hysteroscopists in the U.S. And so she does difficult uterine adhesions all the time. So it's like, we don't need to go outside of our lane and do a tummy tuck and do a bladder lift. And we can, but that's not the best interest for the patient. You want someone that's really doing that all the time. And so I think for the patient, that's always a great question. I'm making a side tangent, but do you do these procedures all the time? Is that what you do all week? And it's sort of like,
that's who you want to go to.
Yeah, that's who you want to go to. Not I've done one before, or I did one last year, or, that's not. And we have no problem sending patients, someone has a hernia. Great. I have a great general surgeon who I love and respect, and I've seen them operate, and they have great hands. And let me send you to them. And let me also send you to the plastic surgeon. Get both of their opinion on how they'd approach the situation. Let's get you an opinion on really how to attack this hernia. And then if we need something else, then we can add in and weigh in too,
I think what I'm taking away from this is, don't be scared to ask questions and find the answers.
Mm-hmm. Yeah.
Sometimes we tend to stray away from medical care because we know it's something and I just don't want to deal with it. But the calm and the expertise that you both have gives me so much certainty that there are answers for whatever we're feeling. So thank you so much for sharing that and your expertise. Tell us where we can find you, because I know you do a lot of educating on this.
We do. www.esse.care. That will work. I am on Instagram as Patient Surgeon Mama, and Dr. Rosen, Instagram handle
Lee Rosen, MD.
Thank you so much. This has been eye-opening.
It was a pleasure.
Nice.
Thanks for having us.
Thank you for having us.
Moms, we're so grateful you're part of our community. Don't forget to rate and review MomCast to help us spread the word, and follow us on Instagram at the Local Moms Network. I'm Dimitra Ganyas. We'll find you back here next week from Stanford Studios.